So let us move on to the session number 7 with the same enthusiasm, which is a panel discussion on neurocritical care. So as we know, neurocritical care provides an intensive care management of patients with life-threatening neurological conditions like massive stroke, hemorrhages, and traumas and other neuromuscular disorders that is life-threatening conditions. Okay, so let me invite the moderator of this discussion. So, doc, Dr. Pradeep Kumar Bhattacharya, sir, so who is Professor Head of Critical Care Medicine, RIMS Ranchi. So, the panelists, let me have an opportunity to invite the panelist, Dr. Abdul Ghafoor, sir, Consultant SICU Department of Anesthesia and ICU, Hamad Medical Corporation, Doha, Qatar. Dr. Lalit Singh, sir, Professor and HOD of Respiratory and Critical Care Medicine, SRIMS, Bareilly. Dr. Santanu Bagchi, sir, Consultant at Tata Medical Center, Kolkata. Dr. M. Radhakrishnan, Professor of Department of Neuroanesthesia and Neurocritical Care, NIMHANS, Bangalore. Dr. Ranveer Tyagi, sir, Director in the Department of Critical Care and Pain Medicine, Synergy Plus Hospital, Agra. Dr. N. Selvarajan, sir, Director of Critical Care Medicine and Emergency Services, KMCH Institute of Health Sciences, Coimbatore. Thank you.
Good morning, everybody. Last session was also basically of a trauma session, and this is also going to be a trauma with a specification of neurotrauma, basically. So, what I am supposed to do is that I have to emphasize more on this ICP monitoring and management strategies. So I'll focus because there are many angles on which we discuss this trauma management, but mainly we'll focus on these ICP monitoring and management strategies. It's all right. Huh? Okay. No. Here I have to see. So, just to start with, these are the typical cases of neurotrauma which comes to our emergency. First of all, I welcome all the panelists here, and I presume that it's going to be a good discussion as far as neurotrauma is concerned with respect to ICP management and ICP monitoring and management. So an 18-year-old man had an unintentional fall from a second-story balcony, and he had a Glasgow coma scale of 5, E1, V1, M3. He has got a normal blood pressure, normal pulse rate in the emergency department. The patient was immediately intubated, and a brain CT scan revealed a linear skull fracture, bilateral frontal lobe contusion, intraparenchymal hematoma, and diffuse cerebral swelling. The neurosurgeon determined that these injuries do not warrant surgical treatment at this point of time, and a ventriculostomy drain was placed in the ICU for monitoring and revealed intracranial pressure. That revealed an intracranial pressure of 26 millimeters of mercury. Now, the kind of injury which we see on computerized tomography whenever it is done, there may be intraparenchymal, there may be extraaxial compartment, or there are many secondary lesions which can happen because of these kind of neurotrauma. So, the principles we have always to keep in our mind, the basic principles of this head trauma management in the pre-hospital setting, then during the transfer of patient to the higher center, whether it is a level 2 or level 3 center, and then advanced neuromonitoring, and the most important is how to prevent the secondary brain injury. For that, whatever we need to do, we try, do our best. So, first of all, my first question goes to Dr. Lalit. What is normal ICP, and when we call it as an intracranial hypertension? Last patient was having 26 millimeters of mercury ICP, And what pressure is our treatment threshold?
Thank you, sir. Good morning to all. It's a pleasure to be here, and thanks to organizer Dr. Pradeep and Dr. Ajit for inviting me. If the question is, what is normal ICP? Normal ICP is 0 to 10 millimeter of mercury. If we say intracranial hypertension, it should be more than 10 to 15 millimeter of mercury. And what pressure is our treatment threshold? It should be around 20 to 25 millimeter of mercury. And but it changed the condition of the patient and clinical scenario definitely, and it modify according to other neuromonitoring rules and changes. It's my observation.
Fine. This is the normal ICP, and when it is more than 10 to 15, we call it as a hypertension, and treatment threshold whenever it crosses 20 to 25. So, my next question goes to Dr. Shantanu. What are the different devices we use for monitoring this intracranial pressure?
Thank you, sir. Good morning, everyone. And I'm really very happy to be invited here as one of the faculty. And it was a great opportunity, excellent conference being going on. And coming to today's discussion regarding the devices for ICP monitoring, the moment we hear the term devices, the first thing that comes to our mind is the some sort of catheters being placed on. And that's true, that's being regarded as the gold standard. So these catheters has been being placed on some specific anatomical locations, like you can have intraventricular catheters, you can have intraparenchymal catheters, you can have subarachnoid catheters as well as epidural catheters. Among all these, the intraventricular one being that the commonly known as the termed as the EVDs, they has been mentioned as the gold standard, and still going by the latest BTF guideline also, they has been mentioned as the gold standard for, because they are very accurate and at the same time they are therapeutic also. You can do some sort of ICP CSF drainage with these intraventricular catheters. So these EVDs being gold standard, they are coming with some pinch of salt, because some of these time, if your process and procedures are not very right, or if this EVD is being kept for a longer duration, in that situations there is up to 20% risk of infection with intraventricular catheters, and also around up to 2% risk of hemorrhage will be there, particularly in patients with coagulopathy. So among all the invasive monitoring devices, the intraventricular catheter or the EVDs being the gold standard, with the risk of infection as well as some hemorrhage, but it allows your therapeutic ICP drainage also. Along with that, I would like to touch upon one more thing, that along with these invasive devices, currently many of the ICUs, and especially those dedicated to the neuro critical care unit, they are using some non-invasive measures also, like your transcranial Doppler, or the one very commonly used in many of the ICUs, that is optic nerve sheath diameter measurement. That those are non-invasive techniques of ICP monitoring.
Thank you,
sir.
Dr. Shantanu. Uh, so, in detail, you heard about on these are the devices which you use, and invasive devices, and this is how they are put. And so, Dr. Shantanu has said in a very detailed manner what about are the invasive devices, non-invasive devices. Now, my question, Dr. Radhakrishnan, what are the indications for ICP monitoring as per the Brain Trauma Foundation guidelines?
Good morning. So, the Brain Trauma Foundation guidelines have given a severe head injury with an abnormal CT scan. That is one of the indications. If the patient has a severe head injury but a normal CT scan, then any two of the following, that is age more than 40 years, abnormal posturing, systolic pressure less than 90 millimeters of mercury. So these are the indications which is given as per the Brain Trauma Foundation guidelines. But suppose if the patient is to go for a long duration surgery for other injuries, during such time there will be no monitoring, that is neuro monitoring of the patient. So in those situations also it is worth putting that monitor. Or if the patient has a polytrauma, there is a chest injury where you want to keep a high PEEP or prone, which are known factors which would increase the intracranial pressures. For in those situations also, you can use an ICP monitor. But this doesn't come under the Brain Trauma Foundation guideline, but these are the other indications which can be used for monitoring the intracranial pressure.
Thank you. Thank you very much, sir. So these are the indications actually. Now, my next question to Dr. Abdul Ghafoor. What are the clinical signs of raised ICP?
Thank you. First of all, I thank the organizers for inviting me to the spectacular event organized in the beautiful city of Bangalore. The clinical signs of raised ICP classically are the headache and nausea, vomiting. And headache is worst in the morning. That's the usual description, and it is also increased with straining activities. Any activities which cause straining that can increase ICP, and also nausea, vomiting also could be there. But we deal with much serious patients in the ICU. Those patients will have other signs. Signs like, first of all, if they have raised ICP, they might have some papillary edema. Usually they have, it happens because of the optic disc get distended because of the diversion of the CSF. And also in severe cases, you might lose the pulsation of the venous pulsation as well in one fundoscopy. And also it might cause abducens nerve palsy, because the sixth nerve is the cranial is the first victim of the raised ICP, because it takes the longest course in the intracranial cavity. And in severe cases, you will have the Cushing's triad. What is Cushing triad? It is hypertension, especially systolic hypertension. So there will be increased diastolic pressure associated with bradycardia and respiratory disturbances, irregular respiration. That is a Cushing triad. And in severe cases, when the patients start to herniate, it will cause the temporal lobe uncus to herniate through the tentorial notch, and this will compress the third nerve, and it will cause pupillary dilatation and also hemiparesis on the contralateral side.
Thank you, Dr. Ghafoor. Now, we must know what are the radiological signs also. So my questions to Dr. Tyagi, what are the radiological signs of raised ICP?
When you see the patient, hello, good morning to everyone. When you see the patient clinically, you find that there may be chances of intracranial hypertension. So you can see by clinically or by radiologically. By radiologically, you have a CT scan, then you find there is a sulcal enhancement in this film. That is the very particular enhancement of sulcal. You can find basal cystal enhancement. You can also find, and herniation. Herniation is late sign usually, but you can find in the late herniation of the, and midline shift. If the midline shift is more than 5 millimeter, more than 5 mm, then you also find the midline shift also. So these are the findings which you find on the radiologically on CT scan. Or in MRI, you find the optical sheath dimension, increase the dimension of optic nerve sheath. So these are the findings radiologically.
Selvarajan sir, how we come to know this, the patient has gone into a stage of impending herniation, and what are the signs which we see that yes, now the patient is about to herniate and we have to be very cautious because of raised ICP?
Thank you. Thank the organizers for inviting us. Impending herniation, probably you will know from the clinical signs of deterioration in the GCS, and then bradycardia, and some patients might even throw some convulsions. And these will be the signs through which you will know that patient is going in for herniation. and some of them may even arrest. Thank you.
Thank you, sir. Dr. Lalit, can you tell me how to interpret this ICP waveforms? Okay, this is one waveform and this is another waveform because
Okay, we have to identify P1, P2, on P3. P1 is basically arterial pulsation, and P2 is a tidal or dichrotic, and P3 is basically aortic close waveform. If P2 is in second figure, P2 is change and it dominant wave, then it reflects the intracranial compliance transformation of this is abnormal compartment or non-compliant cranium. It reflects the cerebral edema as well as the intracranial injury. This is if P2 is loud.
so basically this the cranium transforms into non-compliant compartment. So once it becomes non-compliant, this second type of waveform is usually seen where there is an accentuation of P2. Now, question to Dr. Bagchi. There are some of the pathological waveforms when we monitor this ICP. Can you tell us about these waveforms when we see in ICP monitoring?
Yeah, thank you. See, there is not much rocket science involved here. See, as Dr. Lalit was telling regarding the basic physiology about these waves, this P1, P2, and P3. So, if you look at the waves very specifically, in the first one, you can see the P1 is quite accentuated. So, the P1 component being accentuated, it's definitely indicates there is some systemic hypertension is there because it's correlated with that higher blood pressure. It's get transmitted by the choroid plexus to the CSF, and you will get a P1 accentuation. In the next one, you can see all the waves are getting diminished. So that can happen when you are having some excessive hyperventilation. So all the components are getting down. The third one is a flat line. So as you can guess, this flat line can happen either the EVD is getting open for some CSF drainage purpose, or the EVD is getting completely blocked. In that case, you will get a flat line on this your ICP waveform. Then the fourth one, you can see the P2 component is getting accentuated. So that means your tight brain. So there is intracranial pressure is going up and it's getting deflected from the brain parenchyma, and you will get a P2 component accentuation. And on the last one, you can see that all the components are getting globular. So it shows there should be there might be some impending herniation happening down the line. So that's how you can interpret going by the individual waveforms.
So first one is basically intracranial hypertension, second was excessive hyperventilation, EVD opened or blocked, and then fourth one is limited ICP, that is non-compliant intracranial space, and last one is impending herniation. So this is how we interpret different kind of ICP waveforms. Now, one important thing we see, that is Lundberg waves. So, what is their significance, Dr. Ghaffur?
Okay, Lundberg waves, basically there are three types of waves. The first one is Lundberg wave A type of waves, which is like as described already, is a sustained elevation of the all the components of the ICP wave, and it will last for 3 to 5 minutes. What does it mean? That means that patient is going to herniate. So this means that also means that the CPP is in the critical has gone below the critical threshold of brain ischemia. So you have to escalate your therapy when you see such a type of wave. So that is the significance of Lundberg A waves. And B waves are not that they are ill-sustained, last for 1 to 2 minutes. And the ICP may be around 20 to 25, but it drops immediately. So these are not actually not that ominous, but they are serious. And in this case also, the patient might have reached the lower limit of the autoregulatory limit. And the C waves actually, they are not clinically so much significant. It's actually a reflection of the systolic hypertension.
Fine. So basically, they suggest us about the acuity of condition, the presence of these extreme fluctuation in ICP that and warrants immediate evaluation and therapy. So that is what. Now, another important thing is about sedation. How sedation and anti-epileptics help in ICU management? Dr. Selvarajan.
Thank you, sir. Without sedation, the patient might, sedation or anti-epileptic, sedation, the patient might have, fight with the ventilator or strain on the ventilator, and then it will definitely increase the intracranial pressure. Anti-epileptics, again, if he has convulsions, again, it will increase the intracranial pressure and it might lead on to a serious situation later.
Dr. Shantanu, what is the role of osmotherapy in ICP management?
Yeah, definitely. See, osmotherapy, the term itself means you are giving some hyperosmolar agent intravenous. So you are sending some hyperosmolar agent inside the blood. So what they cause? Their effect, they are having a double effect. One is they create an osmolar gradient for which you are getting, once it reaches the blood-brain barrier, you are getting the water out of this brain tissue. It's coming to the blood. And that's how the overall brain volume goes down, and simultaneously it has a lower ICP effect naturally. And on the other hand, this water which is coming to the circulation, that has a rheological effect, rheological benefit, I would say. So that will decrease the viscosity and that will improve the local microcirculation, and simultaneously the autoregulation will cause some vasoconstriction. So that's how the ICP improves. So both way, it helps, this osmotherapy helps in reduction of the ICP. Now, as I can say, there are some agents issues. See, there are multiple agents, but mostly the recommended ones, either the hypertonic saline or your mannitol. Among these two, the third edition of BTF, Brain Trauma Foundation guideline, they recommended, that was a grade 3 recommendation, they recommended for mannitol. But mannitol has its own side effect, particularly it causes hypovolemia. So once in a traumatic patients with a lot of blood loss and all, you don't want a hypovolemia. And at the same time, mannitol, there is something called coefficient, it is around 1, less than 1. So in that case, there is always a risk of rebound intracranial pressure rising, rebound intracranial hypertension when you are using mannitol, because it can deposit it. Once it reaches the blood-brain barrier, it can deposit it in the parenchyma, and on a contrary, the cranial osmolarity will go up and the brain will start absorbing fluid. So mannitol has these two important, one is this hypovolemia and second is this rebound intracranial pressure rise. So that's why mostly the suggestion, although there is no comparative mortality benefit clear cut between these two agents, but there is a definite deviation towards hypertonic saline use, and usually we use a 3% concentration of hypertonic saline. The dose can be around 1 to 2 ml per kg. And there are some recommendations there, those are old papers, last one being in 2005, they recommended something about 23.4% hypertonic saline also, that was given as a 30 ml bolus. But I have not personally used it, mostly in our center and whatever I have seen is mostly the 3% saline, the 3% hypertonic saline being used at a dose of 1 to 10 ml, 1 to 2 ml per kg. At around, you can repeat it around 4 to 6 hourly, and your target sodium should be on the higher side. Whenever you are using a 3% saline, you should target a sodium around 145 to 155. That is it.
Oh.
And
Yes.
regarding mannitol, you can use it, but mostly the first choice will be your hypertonic saline.
So although Brain Trauma Foundation has not recommended, but we are moving towards hypertonic saline more. Now, Dr. Radhakrishnan, what is the role of these three things? One is hyperventilation, barbiturate coma, and therapeutic hypothermia. These are the three important things which we usually do in ICU management. What is the current status?
See,
all these three interventions definitely reduces the intracranial pressure, but it has its own bad effects. So as far as hyperventilation is concerned, prophylactically there is no point in giving hyperventilation. The reason is immediately following the head injury, the cerebral blood flow is low. And added to that, if you give hyperventilation, you will push the brain to the ischemic range and it causes more damage. So prophylactic hyperventilation is ruled out. But then you have a patient in the ICU, suddenly the surgeon has decided there is a doubt whether to operate or not to operate, and there is some deterioration, pupillary asymmetry happens. Hyperventilation immediately reduces the intracranial pressure, so it acts like a bridge before another intervention could be done, or placing an ICP monitor or the mannitol to take effect, or shifting the patient to the surgical theater. So in that case, it will be very useful. But as a second tier therapy, if you want to use hyperventilation when the sedation and osmotherapy fails, it is always better to include an oxygenation monitor, because we have seen when you hyperventilate, ICP nicely reduces, but when you do a jugular venous oximetry, that also drastically reduces. So it has its own effect, and because of the OD hyperventilation induces alkalosis, the ODC curve shifts to the left, so the brain becomes ischemic. So there is always better to have a oxygenation monitor. Now barbiturate coma, theoretically it reduces the cerebral metabolism, it does reduce the ICP. But the problem with the barbiturate, there are some concern that barbiturate also induces hypothermia. Whether it is the barbiturate effect or the hypothermic effect, we are not sure. But the problem with the barbiturate effect is prolonged. It causes severe infections. So the patient die of infections rather than of raised ICP. So we don't prefer to use barbiturate coma, but if we go more in favor of a decompressive craniotomy rather than trying all these effects.
Agreed.
The third one, therapeutic hypothermia, is also useful, but then we don't have that technology to use induced hypothermia like an endovascular catheter or other sorts of things. And it has also not shown benefit, because we induce at a later stage by which all the biochemical mechanism has triggered in, the neuronal injury progresses, but it does reduce the ICP. But when you look at the outcome, because of hypothermia induced complications, they die of those things rather than the ICP. And the recent multicentric trial have also shown that hypothermia does not have much benefit. So hyperventilation, temporarily it is good. If you don't want to go for surgery, maybe barbiturate may be tried, but then it has its own effects. And therapeutic hypothermia, routinely we don't practice. In the OT sometimes, yes, like for aneurysm clipping, but then as a intervention in the ICU, we don't practice currently in our center.
Dr. Tyagi, you want to say something?
Paper on NEPM in 2015. 2015, no role of hypothermia to prevent intracranial hypertension or any mortality benefit. So better to avoid hypothermia in place of keep hypothermia. So that is the take-home message regarding
Yes.
temperatures.
Now we go to the next part, that is surgical intervention, decompressive craniectomy. It has got a very impressive role as far as raised ICP is concerned. So this question goes to Dr. Ghaffur.
Okay.
What is the role of decompressive craniectomy?
Well, decompressive craniectomy basically are of two types. One is primary DC or secondary DC. Primary DC, you do it when you evacuate any mass lesions, you keep the bone flap open. And secondary decompressive craniotomy is when you have a very high ICP resistant to all the treatment, you go for a decompressive craniotomy. That is a secondary decompressive craniotomy. So this was addressed in basically two studies. These are the two landmark studies, I would say. One is the 2011, they published this DECRA trial, and they found that definitely decompressive craniotomy reduces the ICP and the length of stay, no doubt about that. But what happens with it comes with a price. What is the price? It is the unfavorable neurological outcomes. It was more in case of patients who underwent decompressive craniectomy. But the follow-up, they assessed all this in a 6 months period. And this study has got a lot of limitations. So another study was conducted in 2016, that is the rescue ICP trial. In that, actually, and another problem with the DECRA trial was they recruited the patient early. You know, those patients who had ICP more than 20 for a 15 minutes period, they randomized them for the in the trial, and they did decompressive craniotomy for those patients. So it was much early intervention. Whereas in rescue ICP trial, the intervention was late, and the ICP target also was high. The target was 22, and they randomized the patients after 1 hour of raised ICP, 1 to 12 hours actually. And those patients, they found that the decompressive craniotomy improves the mortality. Whereas in DECRA trial, there was no difference in the mortality, but increases the unfavorable neurological outcome. In this study, rescue ICP, they found that there is a mortality difference. Definitely, the decompressive craniotomy improves the mortality, but there are those patients who underwent DC, they developed more vegetative state, and severe disability also were more in those patients who underwent decompressive craniotomy.
So I think further studies are needed to confirm
Yes,
its position
of course,
as far as.
yeah.
Okay. My next question goes to Dr. Anvir. What is the utility of Glasgow outcome score?
So the Glasgow outcome basically used for the purpose of prognostication. Oh, it's divided basically in 1, 2, 3, 4, 5. So 4 or 5, if a extended Glasgow outcome score, that will be in 4 or 5, that is in the favorable condition. It is 5, that is a good recovery, or 4 is the moderate severity, or 3 is poor chance of recovery, or it will come in the 1, that means patient brain is dead, or 2 is basically the vegetative stage. So this scale used for basically for the prognostication of the patient.
Thank you. So this is the extended Glasgow outcome score, and this is the prognostication score for unfavorable and favorable outcome. Now, a quick answer from Dr. Santanu Bagchi about diffuse axonal injury. That is a problem whenever this kind of patient comes to ICU. So what is diffuse axonal injury, and how diffuse axonal injury is graded? Although we know that outcome of these kind of patients, as far as management is concerned, we don't have much, but at least people should know about this thing. So can you answer what is diffuse axonal injury and how diffuse axonal injury is graded?
Yes, very rightly said. It is associated with the prolonged morbidity of the patient. That's how we address this condition. And basically, it happens whenever you are getting some sort of, you may say, the accelerating, decelerating, or rotating force being applied on the brain. And what happens is that these actions, the actions end get sheared off. So there will be neuronal damage, and that happens in a global fashion. So there will be a diffuse neuronal damage because of the shearing of the axonal ends, and that causes a prolonged vegetative state. Patient goes into a prolonged vegetative state. It's very difficult to win them. They get all sorts of ICU-related complications, and that's how this diffuse axonal injury may be mostly related to a trauma. It causes so severe poor outcomes in those kind of patients who are having, unfortunately, this condition. And regarding grading, in CT, we'll get a proper tight brain feature, and if you can grade, it can be graded on the basis of Marshall's grading. So you are having 4 grades, 1, 2, 3, 4, and the 4 being having the highest mortality risk, and 1 having the lowest mortality risk. In grade 1, you are having no visible intracranial injuries, and you need to check the cisterns. If you can see the cisterns, you can think, and as well as the midline shift is less than around 5 millimeter, you can consider this patient to be in grade 2 of Marshall grading. Once you cannot see the cisterns, or the cisterns are getting compressed, in that situation, the patient goes into grade 3. And the worst one, I would say, the grade 4, once the midline shift happens to be more than 5 millimeter, that has a more than 50% risk of mortality, along with the morbidity what I mentioned in the beginning. So it has to be addressed very prolonged manner, and you need a very meticulous care of any patient who goes into a diffuse axonal injury. You need all the complications of prolonged ICU stay are the risk factor for this kind of patients.
Thank you, Dr. Shantanu. Now, I think we have discussed in detail as far as ICP monitoring and this thing is concerned. Now, one question to Dr. Radhakrishnan, because this is important and very latest. Jugular venous oximetry and partial pressure of brain oxygen monitoring and ICP. World is moving towards this side. What do you feel that this kind of guided therapy actually helps a good outcome of patients or not? What is your experience in a tertiary care center?
We have used jugular venous oximetry, but
Yes.
not in all patients. So we usually place a catheter upwards and then intermittently take the sample. The Edwards have come with pre-sub catheters which has inbuilt fiber optic jugular venous oximetry, but they have abandoned that production now. So alternatively, if you want to do the oxygen extraction non-invasively, one is a NIRS, non-invasive spectroscopy, but that also has a lot of plus and minus. In the Western countries, they are moving more towards the brain tissue oxygen monitoring, which of course is not available in the country. So a brain tissue oxygen more than 20 millimeters of mercury, it's really good. So it doesn't say what the actual problem is, but it helps us to guide whether I have to increase the hemoglobin or whether I have to increase the FiO2. It tells me how to titrate the systemic parameters to achieve the desired targets. Again, brain tissue oxygen is a very local, so it all depends upon where you place the catheter, and you need the surgeons to place the catheter. If it's a diffuse, we usually play on the right frontal white matter, but if it's a localized pathology, then we usually place it on the penumbra because it gives a very focal information. Jugular venous, it usually gives a hemispheric, either on the right side, or if there is a left side is a pathology, you put it on the left side. It is useful for titrating the hyperventilation, and if you want to do a lactate difference or cerebral metabolic rate metabolism, you can measure. But a very high jugular venous oximetry also tells us the outcome is not good because it is usually seen in infarction where there is no oxygen extraction.
So you find that if these things are used simultaneously, obviously we can guide the outcome of patient.
Yeah, it helps us really much because for individualized therapy, a 20-year-old is not the same as a 40-year-old hypertensive. So it helps me to titrate the systemic parameters to achieve the desired brain tissue oxygen.
Fine, sir. Thank you. Now we'll see this thing, rapid fire questions. I'll just ask, you have to answer in just 30 seconds or so. What are the recommendations? Because already we have discussed all those ICP and management. Recommendation of Brain Trauma Foundation for severe traumatic brain injury. So first question to Dr. Ghafoor, what about decompressive craniectomy?
Okay.
You just, what kind of evidences are there?
Yeah, the recommendation by Brain Trauma Foundation regarding decompressive craniectomy has evolved. And their initial recommendation was in 2016, which was actually before the rescue ICP trial was published, but they didn't consider the findings of the rescue ICP trial. And so they said that the decompressive craniotomy as an early therapy, when you fail your tier 1 management measures, then that is not recommended. That was their recommendation before. And also they recommended that when you're doing a decompressive craniotomy, do a large decompressive craniotomy, large frontotemporoparital craniotomy. The size also they mentioned that 12 by 15, and these were the recommendation. But the recent update 2020, they changed it, and now they're saying that you have to do it's not allowed to do decompressive craniotomy as just to improve the outcome, because it doesn't improve the outcome, neurological outcome, but it decreases the ICP. So for that reason, you can still do the decompressive craniotomy. And it can be done also as a late rescue therapy. When you fail your
So-
tier 1, tier 2 therapies, patient can go for
is-
decompressive craniotomy. And they still keep that recommendation regarding the size of the large frontotemporal craniotomy still is there.
This is rapid fire. Please stick to 30 seconds. I don't want more than that. So evidences are just level 2 evidences. Okay, whatever you described, it's all level 2 evidences. Now, what about prophylactic hypothermia, Dr. Lalit?
As already discussed, hypothermia earlier thought there is no recommendation as such, and it's a level 2B recommendation.
Yes, level 2B recommendations as far as prophylactic hypothermia. What about hyperosmolar therapy? Uh, uh, Dr. Selvarajan?
Actually, mannitol is, I think, not preferred, and hypertonic saline is used for getting the thing, pressure, ICP under control.
Thank you, sir. And what about CSF fluid drainage? Dr. Shantanu?
Regarding CSF fluid drainage, there is a grade 3 recommendation. That means it's a low quality evidence, but they are recommending two things. One is EVD is your choice of mode, I would say. So you need to go for a EVD placement, and along with that, they are telling that you need to go for a continuous drainage instead of an intermittent drainage. So an EVD to be placed, and it has to be zeroed around mid-brain level, and go for a continuous drainage. That's being preferred for CSF drainage as per BTF guidelines, sir.
Fine. So all these are level 3 evidences. What about ventilation therapies, Dr. Lalit?
Yeah, it's a very important to ventilate the patient with traumatic brain injury, and target of PCO2 should be around 30 to 35. It should not be less than 30 because already there is reduced cerebral blood flow, and PaO2 is around 60, and PEEP should be minimum or 0. If you are using a hyperventilation, then use the SgO2.
Dr. Ranveer, what about anesthetic, analgesics, and sedatives?
These all anesthetic analgesic all recommended level 2 or level 3 recommendations. Basically, barbiturate we already discussed use for the short period of time when we are planning for the surgery or transfer the patient, like ventilation also. And like propofol you cannot use for long time. It is also causes harm in spite of benefit. So ventilation already discussed, barbiturate already discussed. These are all recommendation level 3 recommendation to use for.
So all level 2B recommendations. Now about steroids, Dr. Gafur.
This is the only level 1 recommendation. That is, the steroids are no more indicated. That has been solved by the crash trial in 2004 itself.
Against.
Against.
It's
You should
against.
not use. It
Yes.
increases the mortality, and the trial was stopped early because of that.
So about nutrition, Dr. Lalit.
It should be used at least within the 5th day, and basic calorie requirement should be meet out, and transgastrogenome is feeding is should be used. It's a level 2 A recommendation.
So all level 2 recommendation. What about infection prophylaxis, Dr. Gafur?
Infection prophylaxis, early tracheostomy is recommended just for weaning the patient early, but not for increasing it doesn't increase the mortality, or it doesn't increase the incidence of VAP. And regarding the oral care also, they found that it actually increases the incidence of ARDS in those patients who received povidone in oral care. And another recommendation is regarding the EVD. They recommend to use the antibiotic impregnated EVD catheters. And these are level 2A recommendations.
Level 2. About, sir, Dr. Radhakrishnan, about DVT prophylaxis, sir. DVT prophylaxis.
See, it's a level 2 to 3 recommendations.
Level 3 or level 2 recommendation, yes, sir.
See, it depends
So-
upon whether patient has an hematoma or not, or whether patient has undergone surgery or not. But they recommend to put IPC stockings at least from day 1. And then pneumatic compression stockings, heparin plus or minus depending upon the patient condition.
So it's combination of both mechanical and
Yes.
chemical
Yes.
prophylaxis. So, what about
rest
seizure
benefit.
prophylaxis, Dr. Santanu?
Regarding seizure prophylaxis, basically it's a grade 2, a level 2A recommendation. So it had some significant validity. And what they have mentioned or tried to highlight, there are 2, 3 things. One is regarding the late post-traumatic seizure. That is what is happening beyond 7 days of your trauma. In that case, prophylactic use of phenytoin is not recommended for a late post-traumatic seizure. On the other hand, once you are having an early post-traumatic seizure that is happening within 7 days,
One-liner,
you
30
can plan for a phenytoin being agent. And one important statement they have added is that despite the widespread use of levetiracetam that we all are might be using in our units, but levetiracetam has not been found to having any significant benefit over phenytoin. So they have not given any recommendation in favor of levetiracetam.
So
That's all
last
regarding the
question
seizure.
to Dr. Lalit. What about ICP, intracranial pressure monitoring? What the evidence is?
Yeah, it's a very important with a TBI patient. If GCS is more than 3 to 8 and patient is salvageable and CT abnormal finding, it should be rule out the hematoma, contusion, edema, and basal cistern compression. If CT is normal with this Glasgow Coma scale and with abnormal posturing and blood pressure is less than 90, it should be a level 2 recommendation and it should be done.
So level 2B. And last question, Dr. Radhakrishnan. What are the indicators of poor prognosis in traumatic brain injury? This is our last question.
GCS less than 8, especially less than 6, that is one. When the patient's present with bilateral fixed pupils, that is the next one. And then absence of brainstem reflexes, or if the patient has very refractory intracranial hypertension not responding to any of the therapy. And it also depends upon the other injuries, polytrauma, which can also affect the outcome of the patients. And age is of course.
Thank you, sir. So this is the outcome algorithm finished. So thank you all the panelists. I presume that the specific question which was put on this topic as ICP monitoring and management, we have tried and covered almost everything. Thank you very much for quiet listening, and thank you all the panelists.